Hello, welcome to your lecture on Chapter 8, The Sick Role. To this point, we've been talking about kind of big macro level processes, right? We've been talking about, first we started off talking about what medical sociology was, and we moved into these differences between different groups and how their health profiles are affected by their position in the social ladder, so on and so forth. This chapter is kind of a departure from all that, and that what we're looking at really here what we're really looking at here is how the how society influences how we view or how we understand the idea of being sick, and how this understanding affects how we act in response to illness. So we're kind of going from a very macro approach, which is big, large-scale things, to a very micro approach, the individual experience. But of course, we'll start off with a history lesson, as we always seem to. Then we'll get into this idea of the sick role and what it means in sociological circles. Now, illness as deviance. So sociologists have typically viewed sickness as a form of deviant behavior. It sounds kind of crazy, right? But deviance is any act or behavior that violates the social norms within a given social system. So if you use that definition, illness or sickness fits the profile. Anytime you're acting out of the norm, according to sociologists, it's deviance. Now, I think in popular parlance, when you're talking to friends or what have you, the term deviance has other connotations. But for sociologists, again, it's just a variation from the norm. So being ill, to continue, can disrupt normal social functioning and is generally viewed as undesirable by both individuals and society. I mean, there are some exceptions. Some people have Munchausen syndrome, but generally speaking, it's viewed as undesirable. Now, such a perspective goes beyond a purely biological definition of disease as an abnormality of the body. So we start with this idea of disease, but it extends out to how diseases affect our social behavior. So some definitions. Disease is an adverse physical state consisting of a physiological dysfunction within an individual. All right, you're probably going to figure that one out. Now, illness is a subjective state pertaining to an individual's psychological awareness of having a disease and usually causing that person to modify his or her behavior. Now, sickness, our third term, is a social state signifying an impaired social role for those who are ill. So, the disease would be, let's pick a good one that people actually get. Mononucleosis, right? It's a disease people get, your age groups, right? That's a disease. Now, just the presence of it, kicking your immune system's butt and enlarging your spleen and what have you, that's the disease. Now, it becomes an illness when a person is like, oh crap, I have mono, and they start modifying their behavior. Like, boy, maybe I should stop licking everybody's glasses, or spitting on doorknobs, or whatever it is that people do for fun these days. So they're modifying the behavior. Now, sickness is when they actually have their social roles impaired, meaning you're not to go out in the public, don't go to class, don't go to work, don't get anybody sick with your sickness. Maybe you're too sick to even go to school, whatever it may be. So it goes from the biological state or physiological dysfunction to a individual's subjective awareness of what's going on that causes them to modify their behavior, and then it moves into, this is where the social impacts are felt. So biological, individual, social. Now, the functionalist approach to deviance would be that it views society. Remember, functionalists view society as a system of interrelated parts. Probably should remember this from earlier chapters. Now, there's an emphasis in functionalism on the tendency of those parts to work together to maintain order and equilibrium. Now, deviance represents behaviors which disrupt normal social functioning and are reduced and or controlled through the application of various sanctions. So, sickness in this formulation can be seen as deviance because it threatens the stability of social systems. The medical profession offsets the dysfunctional aspects of sickness by controlling or preventing disease. So this is how it's all understood in the functionalist worldview. Okay, being sick causes people to eventually opt out of social roles or be excused from social roles. And when you have fewer people operating the roles, all of a sudden you start to have these breakdowns, and what the medical profession does is limits the damage. Now, The Sick Role is a book written by Talcott Parsons, 1951. Sick Role is actually an idea written in a different book. It was a book, The Sick Role later on, but it was introduced in The Social System, which he wrote in 1951. And what he did, and we've kind of alluded to this before in previous chapters, but he developed a complex functionalist model of society in this book, and included in it was an analysis of the function of medicine and the role of the sick person in relation to the social system within which that person lived. Okay, now, we talked about this before. We talked about how this was a bellwether event that brought the field of sociology into issues of health and illness, and it still is true. Now, with this chapter, we're going to get to a little bit more detail about it. Now, the sick role is composed of four basic aspects. Okay, the sick person, number one, is exempt from normal social roles. Now, of course, this depends on the severity of the condition and approval by a physician. But as you guys all know, that if you're sick enough, you can go get a note from your doctor and you can take your test a couple of days later or what have you. You're allowed to do that. The sick person is also not responsible for his or her condition. Illness is beyond a person's own control, and help is needed in order to get better. A sick person is expected to try to get well. Sickness should be viewed as undesirable by the individual. If you think it's desirable, that's pretty deviant. An exemption from the roles and responsibility for illness is conditional on the obligation to get well. You can't just spend your life, licking doorknobs in public places because you don't like to go to school. Most people wouldn't do that, but that's the idea here of the sick role. We all kind of know the rules, right? We all know that it's not your fault you got strep throat. You don't have to go to choir practice when you have it. You should probably go see a doctor. That's number 4. In an attempt to, number 3, get well. You definitely don't want to continue having this affliction going forward. And then when you go to the doctor, the doctor says, "Here, take these pills. You should comply. You should take the pills." These are the things that are expected of you as a sick person, according to Parsons' sick role concept. Now, the sick role concept, as defined by Parsons, also defines patterned expectations of behavior for the patient-physician relationship. Number 1, the physician should work to return the sick person to a normal state of functioning. It's their job, right? Number 2, physicians hold greater power in the relationship, and this allows them to exert leverage over the patient to encourage compliance with medical procedures. Again, this is all stuff written in 1951. So, that's the end of the sick role idea. We'll come back to it, but these are the 4 basic ideas, right? And he took these ideas, and what he essentially did is he kind of created a taxonomy of how people behave when they get sick. And his approach was, or his purpose was, to show that even something as personal as getting a cold has all of these social consequences and also social rules for how one is supposed to respond to it. And that was a big contribution. Alright, so medicalization, moving on. Medicalization is a process by which previously non-medical problems are defined and treated as medical problems, usually in terms of illnesses or disorders. The big piece of evidence here, the DSM-1, that's the Diagnostic and Statistical Manual. Psychologists use it and psychiatrists use it to determine what illness it is you have, right? Whatever your symptoms are, whatever their clinical observations are, they equate it back to this DSM manual that tells them whether or not tells them, number 1, whether or not it's a mental disorder at all, and number 2, what mental disorder it is. Now, DSM-1 and 52, there's 106 different mental disorders. DSM-4, in 1994, had 297. There was a new one that came out, and I don't know the count, but it was larger. So there is this process of medicalization that goes on. Menopause, again, been medicalized. Male baldness, been medicalized. Whereas before, these weren't considered. These aren't psychological issues, obviously. These are different examples of medicalization. But the point being that these were just considered things that happened before. They weren't considered a disorder or an illness to be treated. There weren't medications for it. It was just something that people went through. And what has gone on over the years is that with improved technology and improved abilities of medical science, there have been attempts to mitigate some of the downsides of being human, essentially, and trying to make people's existences that much more pleasant by having treatments for things that, if you take these two things together, most everybody is going to experience. Now, doctors initially responsible for medicalization of new areas of life, the doctors are the ones who are initially responsible for this medicalization of new areas of life, as they sought to expand the boundaries of treatable conditions. See, doctors, like anybody else, wants to expand their sphere of influence. They want to expand what they can do. They're not content to just do what they were doing. They want to keep getting better and more comprehensive. Primary forces driving medicalization now are biotechnology, like we had mentioned before. One thing I didn't really allude to is consumers. Let's remember, people want this stuff. And of course, managed care. Managed care being the process through which all of this business is paid for. Alright, so now medicalization, again, that fitted in, I guess, with the Parsons sick roll business. It fits in that we've created more things that are applicable to this whole sick roll phenomenon by medicalizing more things. So if we medicalize more issues, then people are more likely to be quote-unquote sick, which requires all these mechanisms to kick in. Now, that's a pretty nice, little tidy definition of how people experience illness and what have you, and how different conditions become illnesses, and then how people experience them, and so on. But there are quite a few criticisms of this. Again, it was written in 1951. First one is that it does not account for behavioral variation. 1969, Twaddle described 7 different variations of the sick roll. Parsons' version that we just talked about here was more applicable in 1969 anyways to Jews than to Protestants or Italian Catholics, who had different ways of going through all this, different approaches. Zaborowski in 1952, right around the same time, notes that group differences in response to pain. This was written right around the same time. Noted that Jews and Italians were more sensitive to pain compared to, quote, old Americans, which I believe he just meant people who had been in the United States a bit longer than Jews and Italians. So I'm going to guess, people of German and Slavic and Irish descent. Setting, being hospital versus home, mattered for expression of pain. And attitude toward pain, acceptable levels, and concern with meaning of pain varied across groups. What all this means is Parsons' sick roll idea works for a specific group of folks, according to these guys. It worked for Jews, didn't really work for anybody else. And Zaborowski noted that there are some differences in how sickness is felt, how pain is felt, and how it's expressed. And if there's wide variation in how this illness is experienced by the individual, then it stands to reason that the social consequences are going to be different as well. Also, it does not account for the type of disease. Here's a big one. Very clearly, he's only talking about acute diseases. Acute diseases mean things that you get sick from and then you get better from. These are generally temporary. They're overcome with a physician's help. This is something like strep throat, ear infections, the clap, whatever. Now, it doesn't refer to chronic diseases, which don't really fit this very well because they are incurable by definition, and exemption from social roles is not feasible. If you have chronic back pain, it sucks, and it's going to be an ongoing process, but the fact that you have this ongoing back pain doesn't just mean you don't have to do anything else again ever for the rest of your life to have people take care of you. It had to be pretty serious before that would go on. Most people wouldn't want it. And more to the point, Parsons' model just doesn't really address this. Parsons' model is always assuming this part. Some kind of infectious disease. Now, if you remember the earlier reading, it kind of makes sense. From a guy writing in 1951, chronic diseases weren't really the issue of the day, were they? Most of the diseases that were an issue back then were infectious. And infectious diseases tend to be acute. And so the model fit the historical time in which he wrote this book, but it just doesn't fit what's going on now. Now, it also does not account for variations in the patient-physician relationship. Probably you guys sniffed this one earlier. I'm pretty sure. Relationship changes depending on setting. We're talking about a doctor's private office versus a team approach in hospitals. Preventive care requires a different approach. And it also doesn't apply well to lower class patients. He's talking really mostly middle class pattern of behavior. And if you guys sniffed this out, you get a cookie. Exemption from social roles is not always possible for the poor, despite illness. You guys probably figured when reading some of this Parsons, exemption from social role business. Some of you are probably thinking, yeah, that'd be nice if I had sick time. A lot of jobs, you don't show up, you just don't get paid, and if you don't show up long enough, you get fired. It's a lot of jobs, especially those in the lower classes. And as a result, this idea that illness somehow translates into an exemption of roles just doesn't fit. Now, despite these limitations, the concept of the sick role can be viewed as what's called an ideal type model, meaning it doesn't actually represent reality, any reality that we know. It serves as a benchmark or something to compare the experiences people have to. That's what an ideal type is. And the purpose of that, of course, is to try to dissect the different mechanisms that go on in the process of this sick role manifestation. Alright, so we'll move away from functionalism and go into labeling theory. Okay. Now, labeling theory argues that what is regarded as deviant behavior by one person or social group may not be so regarded by other persons or other social groups. There's lots of examples of this, right? You guys can think of them. For some social groups, smoking pot is deviant. For other groups, it's normal. For some groups, going to the gym every day is normal. For other groups, that would be a deviant act. Again, just different from norm. It doesn't have to be criminal or bad. Now, deviance, again, one thing to really understand about it is it's not a quality of the act a person commits. An act isn't deviance. It's instead a consequence of the definition applied to that act by other people. So there's no act itself that is deviance. It's only deviant if people think it's deviant or say it's deviant. Now, the key to distinguishing among sick roles is this notion of legitimacy. Going on this idea of labels. You have three different types of legitimacy according to Friedson. You have conditional legitimacy. This is temporary exemption from normal obligations. You have an obligation to get well, like what Parson talked about. Colds, even something as bad as pneumonia. You're expected to stay home, get better. Everybody expects you're going to be okay, right? Nobody expects you to die. It's ugly, but you'll be all right. Second one. Unconditional legitimacy. Permanent exemption from obligations, plus you gain extra privileges because of the hopelessness of the deviance. For example, cancer. And what they're talking about here is somebody gets a cancer diagnosis, not one that can be cured very easily, obviously. Nobody expects them to do much other than try to fight the illness and enjoy their last days. Even some extra privileges. Say what you want to say, wear what you want to wear, do what you want to do, so on and so forth. Then you get to illegitimacy. Now, this is where you're exempt from some obligations, but you don't get any additional privileges, and you may actually be something called stigmatized. And these examples are things like stammers, speech impediment, and epilepsy, that's seizures. Now, some obligations you would be exempt from, public speaking, driving, but you don't get anything extra out of it. And people oftentimes will, again, apply this idea of a stigma to you. Now, criticism of labeling theory does not explain what causes deviance other than social reactions to an act. Now, this is criticisms of labeling theory in general. Okay. Now, it does not examine the commonalities among deviant actors other than their sharing of a label, and it does not explain why certain people commit deviant acts and others in the same circumstances do not. So, sickness is social deviance? Well, the deviance perspective limits the ability to examine biological aspects of sickness as a condition of suffering. Now, being ill negatively impacts individual behavior and may result in a negative sense of self, especially in the case of chronic illness. As far as being sick and disabled, being sick is an undesirable state, again for most, despite the exemption from one's usual activities. Unless you're a little kid and you get to stay home because your temper is 102 and you feel fine, you get to stay home and watch cartoons. But in the adult world, that's pretty much the case. Illness disrupts daily routines, causes various degrees of suffering, and threatens ability to plan for the future. Now, particularly damaging to a person's concept of self when illness is experienced is overwhelming, unpredictable, and uncontrollable because it paralyzes the ability to act and manage one's life normally. I mentioned this idea of stigma before. It comes from this guy named Goffman, and it's defined as some deeply discrediting attribute. Okay, that's what a stigma is. There's main forms of stigma according to Goffman. We have abominations of the body, for example, physical deformities, blemishes of individual character, being mentally ill, being a drunk, having sexually transmitted diseases that are known about. Then there's tribal stigmas, race, religion, nationality, and that all has to do with, again, intergroup relations. So stigma, just so we have that definition, ties back, where is it? To here. Number 3, illegitimacy. The slide should probably have been right after that, but I misplaced it. Now, stigma affects health situations in 4 ways. It causes people to experience psychological stress, delays seeking health care due to fears of being stigmatized and the subsequent discrimination, experience of adverse reactions from others in healthcare settings by stigmatized individuals, and slow provision or withholding of resources by communities when stigmatized groups may be the primary recipients. I guess probably the historical example of this would be when AIDS was first being known, right? When people started to finally figure out what this disease was. This would be the early 80s, before most of your times, I guess. And it was kind of a mysterious disease when the news reports first started talking about it. First it was called GRID, actually. Gay-related immune disease, or immunodeficiency, or something along those lines. It didn't get called AIDS till a little later. And people with this disease were very much stigmatized. If you want to go back to this definition, some deeply discrediting attribute, that's certainly it. People didn't want to be near them. People didn't want, they attributed it to, again, homosexuality, which, again, in the early 80s, acceptance of homosexuality is not what it is now. It was considered as, it was only homosexuals and IV drug users, what everybody figured. And at that time, that was most of the folks who did have it. As we know now, it's spread out to the heterosexual, non-IV drug-using population. That's another discussion. It was viewed as being deeply discrediting attribute. As a result, the folks who had this disease, had AIDS, definitely experienced a lot of this, a lot of psychological stress. A lot of them didn't seek out health care until it really became, the disease became very advanced, because they were worried about being discriminated against. It took them a while before they decided that they weren't going to release the names of these patients publicly. At one point, there was a lot of hysteria, and there was notions of rounding everybody up, putting them on an island, everything else, and putting them in sanitariums like they did with tuberculosis patients, and so on and so forth. Now, that never came to pass, but the fact that it was considered is part and parcel with this idea here of delaying. Now, there are adverse reactions from others in healthcare settings by the stigmatized individuals. Again, didn't want to be the AIDS patient on the floor. Slow provision or withholding of resources by communities when stigmatized groups may be the primary recipients. So we had a bunch of gay AIDS patients in the early 80s. The question of how to fund the research or how to fund the attempts for a cure weren't very popular for some time. It was a process. It was kind of this great natural experiment in activism, where you took a very marginalized group with a very marginalized disease and somehow were able to marshal a good amount of support and money for research and so on and so forth. And now, 30 years later, I think I just read something about some pretty effective medications these days. Maybe I think it was on Huffington Post or something like that this morning about a antiretroviral or retroviral medication that had almost a 100% success rate. So 30 years is what it took. But why it took so long and why it was so difficult was because they were fighting against this idea of stigma. Or they were fighting against stigmas, not the idea, but actually the stigmas themselves.